Hi there, my name is Rachel and I'm a nurse consultant with the North Simcoe Muskoka Hospice Palliative Care Network. I'm going to share with you a very small presentation called Oxygen at End of Life. Hope you have some takeaways from it. When we're talking about an individual at end of life, it's important to know what their illness trajectory is. So what disease they have, what the life expectancy of their illness is, what point in their illness trajectory they are at. It's important to know what their palliative performance scale is, what they are physically able to do. Are they mentally intact? Are they eating and drinking? Are they able to move themselves from point A to point B? This will give us an indicator of what stage in their disease they are and if they're nearing the end stages of their disease. It's very important to know what the goals of care for the individual are. What are the goals identified by the individual themselves? What are the goals identified by the family? What is the family's understanding of their loved one's illness? And what is the family's understanding of the life expectancy at the point in time in which your interaction is taking place? What are the goals of the healthcare team? Why is the healthcare team involved? What have they been brought in to do? Are the current goals of the care team realistic? Are they consistent with the care plan? And are they offering benefit and improved quality of life for the person at this time? It's important to know what areas of concern are expressed by the patient themselves, if they're capable and able to communicate still, and what are the areas of concern that are made mention by the family. One tool that we can use is the Edmonton System Assessment Scale. That's a subjective scale in which individuals rate different symptoms on a scale of 0 to 10. Anything that is noted a 3, with 10 being the worst experience ever, is noteworthy and worth having further conversations about to ensure that it's addressed. It's important to ensure that concerns are brought forward by the person, the family, the care team in any of the domains. Part of a good holistic palliative approach is to ensure a diligent assessment is done. It's important to screen all patients, especially for respiratory distress. It's important to complete a history for that respiratory distress or that dyspnea that is being experienced, because it could have many etiologies. It could originate from many different sources, both of which could be chronic or more acute in nature, and would require different interventions or investigations to possibly address and treat. It's important to do a complete physical exam to look, listen, and feel. And it's important to speak about different investigations that might be options at the person's current performance status and that are within their goals of care, to investigate, possible causes for the dyspnea, and then further intervene and help manage and treat. As far as the management of the dyspnea goes, it's important to validate the patient's experience and the family's concerns. It's important to provide information and discuss treatment options for treating the dyspnea. It's important to measure and control specific underlying causes for the dyspnea, and it's important to manage these symptoms both pharmacologically and non-pharmacologically. Oxygen is a common prescribed medication for lung cancer patients with advancing disease. Its indications for use include hypoxemia and dyspnea. Reversal of hypoxemia in some cases will alleviate the dyspnea that's being experienced. Oxygen is sometimes prescribed for non-hypoxic patients to relieve dyspnea, while some patients may benefit from the symptomatic alleviation of the symptoms. Recent studies demonstrate that compressed room air can be just as effective. This raises the question as to whether to continue their oxygen use. The most Effective treatment for dyspnea is pharmacotherapy, particularly the use of opioids for dyspnea. Adjuvant therapies, including pursed lip breathing and a fan blowing towards the patient, air circulating the room, loose clothing. Some patients may come to require high flow oxygen. High flow delivery devices include masks, high flow nasal prongs, reservoir cannulas. Each device has advantages and drawbacks. Eventually, it may be impossible or impractical to maintain oxygen sats that are greater than 90%. The overall goal in treating these patients is comfort rather than to target their O2 sats to be greater than a certain number. It may eventually be advisable to remove continuous oximetry and transition the focus to comfort measures without investigating, but treating symptoms as they arise based on what the patient says they are. It can be intimidating for clinicians to introduce the family to the idea of withdrawing oxygen from an unconscious patient nearing death, as it can feel to them like pulling the plug. We do know that providing oxygen in severely hypoxic patients near the end of life can improve their oxygen levels, but often will not likely adjust their clinical illness trajectory. They still will continue to die. You could say to families in these situations, he or she looks very comfortable. One thing that we try to do in these situations is to look at everything we are doing to make sure it's helping with the comfort and isn't making the process take longer than the natural course of illness. One of the things that might actually be prolonging his or her dying and may not be helping with comfort at this time is the use of the oxygen. We would like to suggest that over the next couple hours, we gradually reduce the oxygen, and as long as he or she remains comfortable, then we can discontinue it. Good communication with families continues to be a definite way to improve end-of-life care. Poor and frequent communication and insufficient information on what to expect can have a negative impact. To make families feel better about their loved ones' care, it's important to encourage them to talk. Ask what the patient was like before his or her illness and invite the family to contribute. Talk to the patient too, even if he or she is unconscious. You can say, we're going to take really good care of you and ensure that what you're saying to family as well. It's always important to have a response ready for when the family says one of those uncomfortable but not very helpful lines. Sometimes family will say, my mom is a fighter. What can you say to this? What they are saying to you is, don't give up on her. What you could say in situations like this is, yes, she has been very strong, but I worry at this time that the illness is stronger. How long has she been fighting? Do you think she would want to keep fighting in this current state, or is she getting tired? Tell me about her. And then what about this statement? Our father wants to live. We often hear this. In a response, you could say, of course he does. You want to validate what they're saying, but would he want to live like this? What would he say if he could speak to you now? People imagine they're going to live the way they did before they got sick, but that is not the case. The first distinction that must be made is between the use of oxygen in an unconscious patient and in a conscious patient. As with all interventions, it's important to explore the hoped for goals of treatment when communicating with family. If the goal is to delay death as long as possible, then oxygen administration may work towards this goal. However, this is not typically a palliative goal for end of life. Often, it's comfort measures. Often, it's to allow a natural death and not to prolong this dying process. If the goal is to relieve dyspnea, the unconscious patient will likely not be experiencing what we would call air hunger, especially when the patient appears comfortable and calm. There may be times when the unconscious patient appears to be experiencing an increased work of breathing. They may have an increased heart rate. They might be using some other accessory respiratory muscles. If there is concern about possible distress in the unconscious patient, like facial grimacing, restlessness, then it is especially important to use medications like opioids before just jumping to the use of oxygen. In the hypoxic patient, if the patient is hypoxic and nearing the end of life, you can encourage the use of nasal prongs rather than a mask, so there's less of a barrier between the patient and the family. Opioids can help supplement the dyspnea and relieve that sensation of air hunger, with the target being to balance comfort and alertness that at a level that's acceptable to the patient. It's important not to monitor the oxygen saturations on a continuous basis, to not focus on the numbers, because the target is now comfort rather than what you're getting in your oxygen saturations. If oxygen is not available in the location in which the patient is, or the patient has decided they don't want to use it, then it's important to titrate the opioids to relieve dyspnea. This will induce a less responsive state, of course, but typically it's required for moderate to severe dyspnea. It's just one of those side effects that go along with the use of the medications. Some medications, some patients find oxygen masks feel more suffocating and they feel more claustrophobic with them. That's why nasal prongs sometimes are helpful, even though the mask might be providing the more needed amount of oxygen. So that's why we don't focus on the numbers that we're getting, what we focus on what the patient can tolerate and what they feel comfortable with. For the non-hypoxic patient, for the awake non-hypoxic patient who are feeling dyspneic, approach this on a case-by-case basis. Sometimes a fan blowing cold air in the patient's direction will help. Sometimes adding opioids and titrating them to effect is very helpful. Oxygen by nasal prongs can be effective and may prevent the need for opioids for a short period of time. Consider all available options depending on the context of the patient's clinical status and the goals of care. One study, which was a randomized double-blind trial, showed that oxygen provided no benefit over room air administered by nasal cannulas in patients that were not hypoxic. So that's the biggest determinant in this case or this study. These were people who did not have low sats in their oxygen. However, they were feeling dyspneic. So the concern with this trial is that people have taken the findings to mean that oxygen provides no benefit to patients when compared to the administration of nothing at all. In this situation, patients did not receive nothing in the placebo. They received some medical air. So in one arm, they received oxygen. In the other arm, they received medical air. Both were receiving something. And remember, they were patients that were not hypoxic. So both of them reported the same level of relief from their dyspnea, whether they had oxygen or whether they had room air. So they did receive something. It's not like they received nothing, but it was room air. So this is an example of medications that are lined up and given at certain points in someone's illness when they are being considered for the removal of high flow oxygen. So one physician in our area uses this as her template. Of course, this is not carved in stone and there's variability to this, but it's always important to ensure when you're taking someone off high flow oxygen and the goal of care is to allow a natural death leading to end of life, to discontinue all bimodal medications, because this individual will not be able to be responsive after this, nor will they be able to swallow medications anymore orally, but they will need to be able to receive their medications in an alternate route. So in this situation, the opioid of choice is hydromorphone or Dilaudid sub-Q, and there is a sub-Q dose every 4 hours with a 1 to 2 milligram sub-Q dose Q2 hours PRN. Ativan as an anti-anxiety agent is given as needed for agitation. And as well, Nosenin is provided 30 minutes before the removal to get that person to a somnolent, less responsive state. And then 15 minutes prior to the removal, midazolam is given, which is a little stronger sedative. And then after it's removed, midazolam is repeated every 15 minutes after the removal until the patient is settled or death occurs. I thank you for your time. If there's any questions, please feel free to email me. My email is Rachel, RACHEL, @nsmhpcn.ca. Thank you for your time.